Facebook page, YouTube, Twitter, Instagram, and I'm hoping LinkedIn as well. I've not used LinkedIn before, so I'm hoping it's going to connect to there as well. Very lucky this evening that a lady called Helen Steel reached out to me when I asked if anyone could teach neuro. As I've said before, it's not my specialty. It's not something that I've ever practiced in. I've obviously seen the odd traumatic brain injury, but other than package them up and ship them out to the nearest trauma centre, ours is the Queen Elizabeth in Birmingham, which is where they go for their neuro care. Other than do that, I've not really been involved with them. I certainly haven't seen things like ICP bolts and EVDs and all those kinds of things. And Helen is going to be talking about all of that. So she's prepared an excellent presentation for us. Why don't I bring her on screen and then you can see what she looks like. So she's prepared an excellent presentation for us. She is going to introduce herself at the beginning of the presentation. So if you are watching us now, it would be nice if you could just say hello. Tell us where you're from, what specialty you're in. Are you a nurse? Are you a student? Are you a physio? Where are you from? It'd be nice to see you in the chat, and you can also ask questions in the chat. Well, there's going to be a Q&A session at the end, so if you've got some burning question that Helen can hopefully answer for us, then I'll keep a note of those as we carry on, and we can have a quick Q&A at the end. So without further ado, I'm going to get rid of myself and Helen, and we are going to crack on.
Hi, my name's Helen Steel. I've been asked by Jonathan to do a session today on traumatic brain injuries and how we manage them in neurocritical care. A little bit about me. I am a ACCP. I've been for the last 6 months. Before that, I did my 2 years training, pretty intense, but got through it. And then before that, I worked in neurocritical care for 4 years as a sister and then 7 years before that as a bedside nurse. So hopefully I've picked up some things along the way. What we're going to cover today, let's have a look. So we're going to go through what a normal intracranial pressure is, and we're going to look at some interesting slides of what traumatic brain injuries look like on CT scan, so you can look super clever in front of people. We're going to look at tonsillar herniation, the thing we're trying to avoid. A little bit of theory, but I've tried to concentrate on the things that are clinically relevant and the things that I wish that someone would have taught me from the get-go, so you know how you're managing, what you're managing and why you're managing it. We'll look at ICP waveforms, ICP monitors, and then the different things that we do and how and why they work. So, intracranial pressure. What is a normal intracranial pressure? So the intracranial pressure is the amount of pressure that exists in your skull at any one time. A normal pressure for URI is kind of 7 to 15. You can walk around like with that pressure, that's your normal. Transiently, your ICP would go up if you sneeze, could go up to kind of 30, but it's quite transient, it comes back down to its baseline. What is the issue is if you have someone with prolonged intracranial pressure. The difference is, this presentation is on traumatic brain injuries. There are some things such as, let's have a look at this. This slide is a glioblastoma. So you've got a big tumour there in the frontal lobe, and the patients become symptomatic because the tumour is so big, but the body has managed to compensate for quite a while because the tumour has been so slow growing. And what we're going to look at is things that happen acutely, where the intracranial pressure shoots up and then you can't get it back down. Interesting. This is what a normal CT head looks like. You've got a nice white skull around it. You've got the midline in the centre, splits the hemispheres quite nicely. It's directly in the centre. And then you've got the squiggly lines. If you think of the surface of your brain, it actually looks like a piece of coral. It's got raised bits, which are your gyri, and bits that go down, which are sulci, so sulci and gyri. And the little darker squiggly lines and spongy looking stuff, that is what we say, oh yes, you've got grey-white differentiation there. which just means you can tell the difference in the texture of the brain, and you know if there's more pressure. If you have more pressure in your head, much like this one over here, you kind of lose that loss of defined colours. And then this CT head in the middle, it's further down, so you know you've now got ventricles in the centre. This is where CSF flows down and then goes into your spinal cord. So they're nice looking ventricles. They're even in shape, and both sides of your brain look the same. So we're going to start off with a game of Name That Traumatic Brain Injury. This isn't something I've made up, I promise. This is on Radiopedia, which is one of my favourite places online to look at imaging. And this is how my brain works, how I found it easier to look at CT scans. One of the neurosurgeons actually showed me this for the first time, and I did think it was made up, but it's not. So this shape here looks like a lemon, quite wide, quite circular. This is an extradural hematoma. So this sits outside the dura, just underneath your skull, and it doesn't penetrate the dura or go onto the surface of the brain. So that's an extradural hematoma. A subdural hematoma is the one shaped like a banana. If you can see this white going along the side of the skull, that is your subdural. And it's that shape because it's trapped inside the dura, which is the thin covering of your brain, and it can't escape elsewhere, which is why it's got that shape. The next slide is a little bit graphic. I apologise, please look away if you don't like it, but this is why the two have different shapes. So surgically, if you have someone that goes for evacuation of an extradural hematoma, what the neurosurgeon will find when they take back the skull and take back the skin and then take out a piece of skull is the hematoma that is sat directly on top of the dura looks like a piece of jelly, and it's quite easy to remove. The subdural hematoma is different because it's stuck underneath the dura. The dura is this white bit, that's the covering of your skull, and the normal CSF normally sits within this. So the problem with subdural hematomas is you've got blood actually sat directly on the surface of the brain, which irritates the brain further and can cause further swelling and edema, which will increase your intracranial pressure. Extradurals tend to have prognostically a better outcome than a subdural hematoma, just because of all the extra edema and swelling that you get with the subdural. Let's have a look. So, name that traumatic brain injury. This one, it doesn't look like a banana, it doesn't follow the shape of the skull. This looks like a lemon, so it's an extradural hematoma. This one is a little bit of a mixed bag. So here you've got a nice ventricle. You haven't got your midline going straight down the middle, which shows us some midline shift, and you've got no ventricle at all on this side, and that's because this subdural here, with some contusions here, are pushing inwards, and it's taken up the space of the ventricle with the brain parenchyma. So this is a subdural. So it's stuck beneath the dura, follows the line of the skull, and that blood is sat directly on the surface of the brain, which is causing a little bit of edema, but some of the edema is also, some of the contusions are also causing some of the swelling as well. This is getting exciting. So we've got diffuse axonal injury. These are pretty hard to see on CT scan. So what a diffuse axonal injury is instead of being hit on the side of the head and having an injury underneath the area of the skull, you usually get diffuse axonal injuries when someone has rolled their car, the brain has been shaken up and it bursts all the teeny tiny blood vessels that you have in your brain. If you have something like an extradural hematoma or a subdural hematoma, the neurosurgeons have got a surgical target. They can go in, they can take the hematoma out, and hopefully it'll reduce some of the intracranial pressure. When you've got something like a diffuse axonal injury, because you've had that shaking and your broken all the vessels and you get teeny tiny petechial hemorrhaging throughout, there's no surgical target to go in and evacuate. So there's nothing that you can do about that pressure apart from take off a little bit of the skull to help it herniate outwards if your intracranial pressure is ridiculously high. These patients normally take a long time to wake up. It takes the swelling a long time to go down, but it's a poor prognostic sign if you've got such swelling. And you would have an MRI to look closer at where the damage is, where the injury has occurred. This one is interesting, or I think so. This is a person who has had cerebral contusions. So if you go back to what our normal brain looks like, don't forget that's got an extradural on it. A midline, like we have there, we don't have a midline here. It's gone off to the side. Ventricles that you have on the first one, there, and a squash ventricle there. If you look over on this one, we actually have no ventricles. There. A bit of a ventricle there, but then completely effaced at the other side. So this is cerebral contusions. We've actually got a subdural hematoma there. You can see the white that follows the line of the skull. And some temporal contusions, if you can see the arrow there. So this A and B were let me click on it. A and B were a gentleman that had crashed his car, had a head injury, quite substantial, and then this was his admission scan. So you can see that he's got midline shift, he's got the subdural, he's got the contusions there, and there's no differentiation between your white and your grey matter there, and we've also lost a ventricle because that's been pushed out. C and D are interesting. So C is when the gentleman's been taken to theatre. It's had the bone, if you look there, we've not got a complete circle, so this is where the bone has been taken out. The extradural has been evacuated and these contusions have blossomed, got bigger. And then this is a couple of days later on D. You can see that we've got a ventricle back. The midline's coming more into the centre but isn't perfect. But you can actually see that the brain is herniated outwards where the skull has been removed because of all the pressure. So extradurals you can take out, blood just sat on the surface. Subdural hematoma you can take out but you risk more swelling, it's more invasive. Diffuse axonal injuries, the brain that's been shaken up and you haven't got a surgical target. And then contusions, you've got a lot of bruising in there, which is what contusions are, and it can take up to 72 hours for the swelling to come to reach its peak. So if you have someone who's got cerebral contusions, they come to ICU, they have an ICP bolt put in, and the initial pressure is kind of in the 20s, which is, you want it around 20 at the most, it's manageable at that point. But what you find is these patients have initially okay ICPs, and in the course of kind of the 24, 48, 72 hours, the pressure does increase and get worse, and then you're faced with whether you need to decompress the patient to relieve the pressure. Next. So this is a very exaggerated head CT. You wouldn't normally see it like this. This is someone who has got, this is their admission CT. This, you can see there's little white dots over here. This is when you have diffuse axonal injury. So if you see the admission CT, don't mind pointing on the screen. If you see the admission CT, you've got nice big ventricles. You can see some grey and white matter differentiation, and you've got a nice midline in the centre. You can just see these little white dots. These little white dots are petechial hemorrhaging. So the gentleman here, you can see it a couple of days later on the next CT scan. He was anticoagulated, so you can see the blood expanding, much bigger. Your midline in the middle, but you've lost the ventricle on that side, and that's because of the blood and the edema but because it's within the brain tissue, within the blood parenchyma, you can't actually go in and evacuate these teeny tiny hematomas. I just thought this was an interesting slide because you can't normally see it this well. I need to get out more, don't I? So what we're looking for when someone's got refractory ICP. So they come to ICU, we do lots of fancy things with them, which we'll go through later. But if your patient's intracranial pressure is reaching a point where it's imminently life-threatening, you can get several signs that you can kind of see. You have a massive spike in blood pressure, your heart rate drops and your breathing becomes erratic, or you become apneic. This is because the brain realises that there's high intracranial pressure. It's not getting enough perfusion, so the hypothalamus quite cleverly stimulates the sympathetic nervous response, and what it does is it vasoconstricts all your vessels to increase your cardiac output, to increase perfusion to its head, because it's trying to save itself. It's aware that there's not enough perfusion there for its needs, it's not getting enough oxygen, so it increases its own blood pressure, which I think is really clever. So that helps try to perfuse the brain. The parathetic response to the increased into the hypertension is to drop the heart rate to compensate for this. So you'll see someone that will be profoundly hypertensive and then they'll become bradycardic. And they might be, well, they should be ventilated by this point, you wouldn't imagine. But they'll also kind of have an erratic breathing pattern, or look like chain stoking, or be completely apneic. And that's because the irritation to the medulla, the respiratory centre in the brainstem, is being irritated by the excess pressure. And this results in an autonomic storm. So what you'll see is you'll get super high blood pressure, super low heart rate, erratic breathing, and then it'll kind of all come back down to normal. And then you'll get super high blood pressure, and then you'll get a super low heart rate, and it'll come back to normal. This is an autonomic storm. It's your brain trying to start out the perfusion and trying to figure out what's going on, but maintain adequate perfusion to itself. It's trying to self-preserve, basically. What happens if you can't do anything about the intracranial pressure? At this point, you would give mannitol to kind of suck any extra water from the brain, osmosis, reduce the intracranial pressure so you've got time to get a CT scan and you've got time to go for an emergency surgery. You'd also find at this time that the patient would have fixed and dilated their pupils, which shows the intracranial pressure is impacting on the optic nerve and causing the pupils to vasodilate, not vasodilate, to dilate. So tonsillar herniation is basically what we are trying to avoid. All the time a patient is on neurocritical care, we're trying to avoid high ICPs because we don't want it to lead to tonsillar herniation. So I keep saying this, but this is a really interesting image. On this side, we've got a normal brain. So you can see, this is an MRI, you can see the nice grey-white differentiation. Look, beautiful. You can see the brainstem and the defined lines of the brainstem going down. And you can see the cerebellum, which has a nice leaf-like appearance. Beautiful. If you go over to the next one, this is also an MRI, you can see that we've lost the grey-white differentiation. The brainstem doesn't have a nice, clear, defined line anymore. And the cerebellum has lost the leaf-like appearance because of all the swelling and edema. It's blown out, excuse me. So you can see quite clearly that the intense pressure has caused all the differentiation to swell outwards, and it's pushed this part of the brain down into the brainstem and gives like a cone-like appearance. This is when we say someone has coned because of the appearance of this. And what the problem is you have a foramen magnum, which is where it's the hole in the base of your skull, which your spinal cord goes down into, and it's because the intracranial pressure has been so high, it's squeezed through that tiny hole and caused irreversible damage to your brainstem. Your brainstem is the part of your brain that deals with all your unconscious functions, so your heart rate, your blood pressure, breathing. And if you are considered brainstem dead, you have lost the ability. It's an irreversible capacity for consciousness and awareness. We'll do brainstem death a little bit later. So, the theory behind it. Monroe-Kellie hypothesis says that your brain is a rigid box and it's filled with 83% parenchyma, which is brain tissue, 11% is CSF, which is produced in the choroid plexus, circulates into your ventricles in your head and then comes down into your spinal cord, then it's absorbed into your system. And then blood, so you've got arterial and venous blood to make sure it gets a good supply of oxygen. I like this little diagram here. It shows your brain as it normally is, CSF as it normally is, and then venous and arterial blood. If you have a mass, in our case we're talking about hematomas as opposed to space-occupying lesions or tumours, you will get an increase in mass and then the CSF will displace itself into the spinal cord. I think this is super clever, but it can only do this to such an extent. As the mass expands, the CSF can't decant any further into the spinal cord, and that's when it starts pushing on the brain and increasing the amount of space that the brain would take up, which increases the intracranial pressure. I love a diagram. So why we're bothered about ICP clinically? We can't do anything about the injury to the brain. We can't reverse it. All we can do is prevent secondary injury to the brain. So the brain is incredibly susceptible to hypotension and hypofusion. So we need to make sure that the brain's getting a good supply of perfusion and a good supply of oxygen. So what do we do in ICU? Well, we give oxygen, aim for PaO2 of about 10, and we aim for increased perfusion to the brain. And this is why we insert intracranial pressure bolts. So ICP bolts go in. We can measure the amount of pressure in the cranium. We can try to offset that extra pressure by increasing perfusion, by increasing blood pressure that we're augmenting for the patient. So how do you work it out? So on ICU, like a cerebral perfusion pressure of 60, that makes sure that the brain is getting exactly what it needs in terms of perfusion and oxygen. You work out CPP, ideally around 60, by looking at the map and then reducing the ICP, which tells you how perfused your brain is. So if you have got a patient that has come through A&E, it's got to neuro ICU, and you haven't yet got an ICP bolt in, you assume the ICP is around 20 until proven otherwise. That way that you are preserving as much perfusion as you possibly can. So you aim for a map of 90 when they first come in. So your patient will come in, they'll have adequate fluid resuscitation. These patients aren't always single organ trauma. Sometimes you can have hyperfusion because they've got other injuries as well, but you would add that in. We're not going to discuss that because this is just isolated head injuries we're going through. So your patient would have adequate fluid resuscitation, and then you start them on pressors of some description to push up your map to 90 until you get your ICP vaulting. So if you have a map of 90, you're assuming your ICP is 20, it means you're getting that CPP of around 60, which is what we want. Let's have another look. So the higher your ICP goes, the higher you're having to push your blood pressure, which is fine until you're finding that you have to augment your blood pressure to something ridiculous like a map of 150. If you are going to a map of 150, you're going to compromise your blood-brain barrier. It's not ideal, so you wouldn't necessarily keep chasing the ICP. We'll look at autoregulation in a second. So we're looking at ICP monitoring in severe traumatic brain injuries. I don't know if you know, but traumatic brain injuries are based on your presenting GCS. So if you have a GCS of 15, there's no head injury, obviously. Then you have mild, moderate, and then severe is a GCS of 8. If you have a GCS of 8, you are at the conscious level where you might not be protecting your airway. So at this point, you're usually intubated and ventilated. Sometimes what you find is that patients that come in through A&E might not be at the point where they're tubed if they've got a head injury, but they might be really irritated, really agitated, vomiting, and not be able to tolerate lying flat in a CT scanner. So sometimes it's not the low conscious level, but it's the level of agitation that ends up being intubated and ventilated to facilitate the CT scan so you can see what's going on intracranially. We use ICP monitoring to direct a stage therapy. So different units use different flow charts, different tiered systems, but it's all based on the Brain Trauma Foundation guidelines, where you look at different aspects of what we can manipulate to reduce that ICP, which we'll go on to in a second. What you find is that if someone has got sustained high ICP, it's associated with poorer outcomes, which is why we're so focused on reducing ICP. If you find a patient has a head injury, sometimes it's a fall or a car accident, if they've ended up with facial fractures, what you can sometimes find is you might get rhinorrhea, which is CSF that leaks from the ear. You might end up with otorrhea, which is a CSF leak from your nose. Sometimes can look a little bit bloody because of the trauma the patient sustained. But if you get a urinalysis dipstick and the section that has glucose on it, if you dip that into the fluid and that's positive for glucose, it's definitely CSF that's coming out of the nose or the ear. And that tells you that the brain is displacing CSF because it's trying to compensate for the high intracranial pressure. With facial fractures, what happens is if you break certain bones, it allows the bones in the face to move forward, which decompresses the brain if there's high intracranial pressure. So if these patients come to ICU, they have an ICP built in, you'll find that the pressures aren't really high because it's already compensated by moving this bone forward. It's incredibly clever stuff. But then you're faced with the decision of, do you fix the facial fractures, which will increase your ICP, or do you leave the facial fractures, which you know are decompressing, until a later date? But that's a discussion with your max factor surgeons and your neurosurgeons, trying to work out what's best for the patient. Autoregulation. So this is a really wordy slide. Have a drink. Autoregulation, cerebral autoregulation is, this is really basically put, if your brain realizes that your blood pressure is dropping, what will happen is your vessels in your head open up so they can get the best share of the blood flow. And if they find that your blood pressure is getting high, what the vessels in your head do is constrict to make sure that the brain isn't overloaded with all this extra pressure. That's a normal response. So if your blood pressure goes up, your vessels in your brain shrink down. If your blood pressure goes down, the vessels in your head get bigger to make sure they get their fair share. If you have a patient with a severe brain injury, what you can get is a loss of autoregulation. So if you try pushing the blood pressure up, instead of the ICP coming down because the vessels are smaller, what will actually happen is that you push the blood pressure up and the vessels in the head get bigger, so the ICP goes up, and vice versa. So sometimes your neurosurgeon or your consultant, neuro ICU consultant, might come across and say, right, let's take a minute. If we're pushing blood pressure up to a certain extent and the ICP is still ridiculously high, shall we come back down slightly on our pressors to see if the ICP follows suit? Obviously not by a massive amount, but by a couple of mils to see if the patient has lost autoregulation. If you've got a patient that has lost the ability to regulate their own cerebral volume, then it's quite a poor prognosis, and these patients are referred to as being pressure passive or having a non-compliant brain. It's a bad sign, basically. So, types of monitors. There are different types of monitors. A lovely little diagram here showing whereabouts in the brain they are. I am a very visual learner, so I tend to find that I'm a visual teacher. I apologise if this doesn't help for you, but this is showing where the different monitors go into. ICP monitors are done on neurocritical care on the actual unit. It's done with a Zimmer drill, which, if you don't know what Zimmer drill is, it's a handheld drill with a little wind thing on the top, and that drills through the hole in the skull, helping place the ICP monitor. As a bedside nurse, your responsibility is to look after your patient and make sure they have adequate sedation. Sedation ICU on neuro ICU is much heavier than sedation you have elsewhere because you're trying to reduce the metabolic rate of the patient. But if you've got someone drilling into your skull, you're going to need a little bit more sedation. It sounds really harsh, but you would make sure you go up on your propofol, make sure you go up on your alfentanil, and you would also monitor cardiovascular signs of pain. So is your heart rate going higher? Is your blood pressure going higher? Do they need more sedation to tolerate this procedure? So that is the fibre optic interparenchymal sensor, the ICP monitor. We do call this an ICP bolt. Interparenchymal is just a fancy word for brain tissue. So it goes into the brain tissue and monitors what the pressure is inside the cranium. Sometimes you get some drifting when these ICP bolts have been in for a couple of days, and then that's the decision of the neurosurgical team whether they want to replace the monitor. Sometimes you can get a monitor that goes in. It's actually sat in a contusion where the bruising is, the swelling is, and then it'll give you an excessively high ICP, and when you do a CT scan it won't reflect the ICP that you've got. So again, that would be the neurosurgeons that come and alter the placement of the sensor. So that is the fibre optic one, which I personally see more frequently. Some units use an EVD. So what this contraption is it's a device, it's the ventricular one here. So it's a device that goes through your skull with a Zimmer drill. This drain is inserted in theatres because it is so invasive. So a Zimmer drill through the skull, through the brain tissue, and then it sits in a lateral ventricle, and that is where all your CSF lives. So what the benefit of these is the internal ventricular drain. It's set at a certain pressure. You can monitor your ICP through these devices, but if your ICP is getting too high, you can also drain off CSF. How clever is that? But it's not because you've got an abundance of CSF in there. It's not hydrocephalus, which is what that is. It's decanting some of your CSF to make space for the expanding hematoma and reducing your ICP. The problem with these is that they are so invasive, there is a massive risk of infection, and you do sample these every few days to make sure there's not any infection in that site. So ICP waveforms, you don't really need to know this. It doesn't affect your personal practice as a bedside nurse, but it makes you look super clever if you can go, oh yeah, I totally know what that means. So when your doctor's around your bed space looking at the monitor, what they're looking for is a waveform. So you've got P1, which is a percussion wave. This is at the highest. This is your arterial blood flow. And that's the highest peak. It then comes down to peak 2. P2, the tidal wave, is a reflection of your intracranial volume. So it should be slightly lower than P2. Then you've got P3. P3 is where your pressure is coming downward. It tapers down until it's got the closure of the aortic valve. And that's a normal brain. That's normal waveform. If you have someone with a raised intracranial pressure, you'll find that their waveform is P1, where the arterial pressure is, P2, is higher because the intracranial pressure is higher, and then down to P3. This is a non-compliant brain. So if P2 is bigger than P1, it's limited intracranial compliance. So it reflects if the numeric value of the ICP reflects the waveform as well. So we're now on to how do we medically manage the ICP in the clinical setting. So like I said, all the guidelines that we've got throughout the country, whichever centre you work in, will be based on the brain trauma guidelines, which were last reviewed in 2020. Again, this is severe head injuries we're looking at, so GCS 8 and below. And we'll look at the simplest things first. So if you get the basics right, hopefully you don't have to progress on to the next level of treatment. So what you want to do with your patient is make sure they are positioned right to increase venous return. So you wouldn't have your patient laying flat on ICU. You would have them tilted, the bed tilted at 30 degrees, not head up, but the bed completely tilted. And that increases venous drainage from your brain down into your thoracic cavity. What you don't want to do is you don't want to, my hands look really big on this, you don't want to sit the bed up and bend the patient in the middle, because as you bend the patient, you increase the thoracic pressure, which stops blood coming down into the thoracic cavity. So don't bend them, tilt them. You also want to make sure that your neck ET tapes shouldn't be too tight, shouldn't be occluding the jugular veins, because that impedes venous return. And also patients with an unstable C-spine with a collar on, as a lot of these patients are, because we can't clear the spine until they have extra imaging or they're awake, you can loosen the collar at each side so it's not impeding your jugular veins. And you can also discuss this with your neurosurgeon, see what they're happy with. What you might see is neurosurgeons, if they're not completely convinced if an ICP bolt is working, you will see them press at the sides of the neck and obstruct the jugular veins. And what this does is it impedes venous return, and you can see the ICP will go up quite quickly on the monitor. And that is just showing that the ICP is working as it should be. Only really transiently, obviously. But it's an indication of whether it's the bolt that's the issue. What else do we do? We cool to normothermia. We don't get these patients get too hot. Because for every degree that you get warmer, your metabolic rate for oxygen consumption increases by 6 to 9%, which is quite substantial. There have been several studies into this, the Polar trial in 2008 and the RCT Eurotherm trial in 2018, sorry. And what these two trials looked at in traumatic brain injuries is whether actually actively cooling patients to hypothermia improved neurological outcomes. They concluded that there was no improvement in clinical outcomes, and there was actually an increase in patients passing away from complications such as chest infections or issues with coagulopathy due to the hypothermia. So now we're just aiming for normothermia. We keep the blood glucose between 6 and 10 using variable rate insulin infusions. Some places do prophylactic antiepileptics for 7 days, some places don't. It's down to your particular unit or your centre. Where I work, we do use it because these patients are likely going to be asleep for up to a week. You can't assess them for seizures, and you would have BIS monitoring or CSA monitoring on there, but you don't want your patient to be subclinically seizing and you not know about it whilst they're sedated, because prolonged seizures are associated on their own with poorer outcomes. We also don't want to give them too much fluid because we don't want to increase their cerebral edema. And as we said before, you want to aim for a MAP of 90 until you get an ICP device in so you can manipulate it. Excuse me. So sedation. Different places use different sedation, but there's usually a tiered approach. Like I said, ICU sedation is aimed at tube tolerance, and if patients are able to tolerate ET tubes and things like that. On neuro ICU, what we're aiming for is a deeper sedation, so we can reduce the metabolic rate and therefore decrease the ICP. We usually start off with propofol and alfentanil in for a RAS of 5. And if this doesn't work, the ICP is still high, would increase the rates first, but then we'd look at adding in something like midazolam. Excuse me, we give a cheeky little bolus, and if this bolus reduced the ICP by 2, it shows it's effective, we would then start an infusion. After that, you've got ketamine. Again, you give a cheeky bolus, and if it reduced the ICP by 2, then you commence the infusion. And then you've got muscle relaxants. So you would start atracurium or cisatracurium to reduce ICP surges due to noxious stimuli. Meaning, if you're prodding and poking your patient, to do mouth care, do eye care, turn in frequently. One, you would cluster care, so you're only doing interventions at one time with your patient and then letting the ICP settle. But you would look at muscle relaxants and whether they need that to reduce the ICP surges. If you get to the bottom of this list of muscle relaxants and all the sedatives, then you're kind of running out of sedative options. What's next? CO2 manipulation. So normal ICU, you're aiming for a normal CO2. On neuro ICU, we manipulate CO2 to manipulate ICP. So carbon dioxide is a vasodilator, so it makes your vessels bigger. Not just in your head, but in your head, it makes your vessels bigger. As your CO2 gets higher, your vessels get bigger. You get more volume in your head, so your ICP is higher. If you reduce the ICP, if you reduce the CO2, the vessels get smaller, so it reduces the ICP because you've got less volume in your head. So we would manipulate CO2 down to about 4.5 to 5 kilopascals. The lower that you can take it lower than 4.5. The lower you take it, the smaller the vessels, and your ICP is lower. Fabulous, you've cured it, you've cracked it. But the longer you do this for, you're going to cause ischemia and you're going to cause infarction. So 4.5 to 5 is usually your limit of how far you can manipulate that down. But that's how we do it, to reduce vessel size, reduce blood volume, and therefore reduce ICP. Osmotherapy. So osmotherapy is trying to reduce the edema that's in your brain by removing the extra water that's in there. So we use hypertonic saline. This is a controlled drug, lives in the CD cupboard, obviously, and this is done centrally only. You can't give it peripherally. So you give infusions of 30% saline. It's just as effective as mannitol, and we would manipulate someone's sodium level, which is what we're doing here by reducing the amount of edema, up to a target on the formal bloods, up to a 150, 155. You wouldn't take it higher than that because then you're going to get complications. It has no diuretic action, doesn't make you pee more, and we normally have infusions of this that are ongoing. And then once your formal bloods get to a sodium of kind of 155, then you'd have to stop it. Once your patient is over the acute phase of the traumatic brain injury and you're correcting sodium, you don't want the sodium to drop from where we've augmented it up to 155 down really quickly, because you can cause central pontine myelitis, which is when you demyelinate your pons, which is irreversible damage. What you might have seen also is mannitol. So mannitol is usually used to buy us time. It's not usually used on the neurocritical care unless we have a fixed pupil and we need time to get CT scan without that patient herniating. It's also used pre-hospital and in resus to allow them to do the same, just to buy time. So this does have a diuretic effect. It's a complicated mode of action, which I don't fully understand, I'm not going to lie. Where it does cause hypotension, hypovolemia and renal impairment. So it's pretty nasty stuff. And if you ever spilt mannitol, I think it's fascinating. But if you ever spill it, put some in a little pot that you're not using, obviously. And as it dries into little crystals. It's amazing. But imagine that and what it's doing to your insides if it's that salty. Let's have a look. What's next? Refractory ICP. So if we've got to the point where we've gone through all the sedation, we're on propofol, fentanyl, midazolam, ketamine, and neuromuscular blocking agent as well, it's then down to a neurosurgeon and the ICU consultant as to where we go next. You can look at thiopentone. Thiopentone is a barbiturate, and it can reduce your metabolic activity by 50 to 60%. If you see someone started on thiopentone, it reduces the ICP quite impressively. But there are issues with it. It's got a ridiculously long half-life, to the point where you'll have to wait days after stopping sedation so you can send thio levels off. So if your patient's not waking up, you can say that it's definitely not the thiopentone still in their system that's keeping them asleep. So you have to send off levels. It can fix and dilate your pupils, so your pupils will get bigger, which is normally because of pressure on the optic nerve, but in this case it's due to the barbiturate, which will fix and dilate your pupils. You'll end up in CT scan, but hopefully it should say that there's nothing acutely on your CT, it's just the effect of the thio. Causes hypotension. And the other thing with thiopentone is you can get rebound hyperkalemia when you stop the infusion. So with thiopentone, you'll start your infusion, your ICP will drop, your numbers start looking better all of a sudden, but you'll find that you have to supplement your potassium. Usually ends up being central potassium, and you would aim for around 4 to 4.5 in a normal setting. The problem with these patients is the thiopentone actually accumulates intracellularly. So you keep throwing potassium at a patient and they'll keep taking it, but as soon as you stop the thiopentone infusion, the intracellular potassium goes back into your circulating volume, causes a massive spike in potassium, and then your patient would have a hyperkalemic arrest, which can be fatal, obviously. It's something that's avoidable, so you would aim for a potassium of 3.5 to 4 at the very most, or you tolerate it lower. It depends on your discussion with your ICU consultant and your neurosurgeons as well. Insertions of EVDs. So this was mentioned earlier because you can have an EVD as your ICP monitor. If you have an interparenchymal monitor and your ICP is refractory and you've got all this sedation on board and your neurosurgeon does a scan, and what they might want to do is put an EVD in, an external ventricular drain, into the lateral ventricle. So yes, they already know what the ICP is, but they can drain off some CSF. And this might buy them some extra time before they have to think about doing anything, any invasive surgery. So if your EVD doesn't work, what's your next option? Some neurosurgeons don't do this. Some neurosurgeons do this. It's personal preference. Research has shown, I've forgotten what the research trial was for. I think it was Rescue ICP, which compared decompressions to patients that were fully medically managed. what they found is that the patients who are decompressive craniectomy, which is where they're taken to theatre and this bone is removed so the brain can herniate outwards, it relieves the pressure, it improves survival, so your patient will survive, but because the brain damage is already irreversible, is the fact that these patients are left in a persistent vegetative state, so they may never regain consciousness even though they've survived. So you need a very honest discussion with your family when you're discussing decompressive craniectomy, because you may survive, but it depends what level of independence that person would be happy to be left with. And this would prevent tonsillar herniation. So what happens when you take brain out and your patient survives? Well, this is what happens. So this edge here is where the skull has been taken off. This is a bifrontal craniectomy. You can just do one side above where the hematoma or the contusions are, or you can do both sides to let the brain fully herniate outwards. So what do you do with people like this? Well, the bone is kept in sterile in theatres in a fridge. Then what they do is they take out the bone, send it off, and they make a replica of the bone with a titanium plate. So the patient would come back in and have a cranioplasty. So what that is they open up the skin, they insert the titanium plate, and then they close the skin, which will give you the appearance of a normal skull. It's fascinating. So, in summary, patients without an ICP vault that have just got there, you aim for a map of around 90, and so you get an ICP and you can manipulate the exact number. Aim for normothermia, just avoid pyrexia. If your ICP is above 25 for 30 minutes, despite your tiered intervention, your increase in sedation, positioning, CO2 manipulation, you call in neurosurgeons. You're going to end up in CT scan, but you need to know if there's something happening on your CT scan. Is there a reason why you've got higher intracranial pressure? Do they need any surgical intervention? Do manipulate your CO2, but not lower than 4.5 because you're going to risk ischemia or infarction. And then hypertonic saline. We do use hypertonic saline for osmotherapy, but not beyond the kind of 155 mark because you're going to run into complications. And on neurocritical ICU, we never give glucose IV. And that is because as you break down the glucose, a byproduct is that of water, which can increase your cerebral edema. So that's the reason. And these are all my references of all the CT images. I find it fascinating, but I do need to get out more. Any questions? Thank you for listening, everybody.
Thank you, Helen. That was brilliant. I've certainly learned an awful lot. I'm probably going to have to go back and revise some of that. Some really interesting points. We did get only one question, so this is your chance to ask questions if you're still with us. We have had up to 50 people watching, so if you've got any questions, now's your chance. I had one question from Martin, which was, where can you see an increase in the ICP on a CT? I'll let you answer that one, Helen.
Okay, so if you have a patient in the ICU and your numeric value of your ICP goes up, you would do a CT scan. You wouldn't see it just in one place, but you can see if there's global swelling. So, you know, the grey-white differentiation, you'd see less, you'd be able to see the differentiation between the colours less. It just looks more swollen and kind of looks all the same colour. Also, the ventricles would look smaller as the CSF is displaced, and you can see if there's less room around the brainstem as, again, the CSF gets displaced.
So it's reasonably obvious then on a CT you can see something like that.
Yeah, your neurosurgeons would review your scan straight away, but obviously you can see something like an expanding hematoma. You can see the hematoma's got bigger, or the contusions have.
Okay, lovely. Well, that's all the questions we've got so far. There may be a few more that may come up at a later date. This presentation will stay on Facebook for 2 or 3 days. And then, with Helen's permission, I'm going to convert it into a podcast as well. I know there's some visual stuff in there, but I think there's an awful lot that you could gain from it anyway without some of the visual aspects of it. And if you use your imagination, I think you can understand what Helen's talking about anyway. And I'm hoping that Helen's going to come back and do some more stuff for us. Is that right, Helen, or have I put you on the spot?
No, you're all right. I could do a subarachnoid hemorrhage teaching, if
Okay.
that's what people will be interested in.
Excellent. So there we go. So we've booked Helen already. We haven't got a specific date in mind, but I'm sure that's something that she and I can coordinate. So I hope you found this useful. If you have, tweet about it, Facebook about it, whichever social media channel you're on. You can get in touch with Helen. Her email address was on the last slide there as well if you've got any questions for her. And just let people know that we're going to be doing more and more of this. I'm going to try and find some experts. I've just got in touch with a specialist nurse in organ donation who was once a clinical lead in organ donation, who's going to be talking to us about organ donation and the implications it has for obviously the family and us as the healthcare practitioners looking after those patients. So I see them from time to time, but I think a lot of us don't see them very consistently. You may get a patient that needs that kind of care and you will see the organ donation nurses, but then you may not see one for another few months, and we'll hopefully talk about things like brainstem death tests and how you're going to care for these patients and the kind of process that they and their family are going to go through. So that's another one to look forward to. So there's 2 more for you to come back to. So thank you very much, and keep an eye on the social media channels, and I'll let you know when the next ones are due. So thank you, and thank you to Helen very much.
Thank you.